In this video, we'll start our discussion of disease screening, which is an important issue in medical and public health practice. Specifically, we'll discuss biases that come up in studies of screening programs. So, screening refers to the administration of procedures to detect disease before individuals would normally seek medical care or treatment for the disease. For example, screening is common for many different types of cancer. The hope in detecting cancer at an early stage is that medical professionals can carry out the confirmations or procedures needed to stop the disease or to slow its progression. Screening seems like a universally useful thing, but we should consider this carefully. First, is it even feasible to detect the disease earlier? Second, is the screening test accurate? We'll discuss this more in the next video. What are the financial, resource, and emotional costs of the screening tests? And similar to how we thought about impact in cohort studies, what is the potential impact of screening, which we can view as the treatment or exposure variable? Ideally, screening would result in much better outcomes for many people. So, to understand the potential impacts of screening, it's also important to consider the natural history of disease in an individual. This refers to how disease typically progresses in a person and is shown in this diagram. So at some point, disease develops in an individual. There's some biological onset triggered by a key mutation in DNA or some damage to tissue. The impacts of the disease in the body continue to develop, and there is conceivably an earliest point at which we would be capable of detecting that disease. This would be limited by the state of our current technology, but hopefully, as technology improves, this point gets closer to the actual biological onset. Eventually, the disease would progress to a state where a person would start to exhibit signs and symptoms, which might prompt them to seek medical attention. At this point, a diagnosis would be made and a treatment initiated. So, thinking about this course of the disease, there are some points at which it would be ideal to screen and points at which it would be ineffective. Implementing a screen that tends to catch people between points 1 and 2 would be an ineffective screen because we would essentially always miss the disease. Ideally, we'd like to implement a screen that catches people between points 2 and 3. A screen that catches people at point 2 would be perfect, but practically impossible. A screen in this period would best poise us to treat disease early and manage it well so that outcomes are overall better. Often, once a final confirmatory diagnosis is made, at least along the progression in this diagram, the disease is at an advanced stage where it's getting too late for interventions to be as effective. The interventions might be too dangerous, or the disease might be irreversible at this point. There's a term called lead time, and it describes the time between the point of earliest possible diagnosis and the time at which clinical diagnosis is usually made. So, if the lead time is short, so for a quickly progressing disease, screening might not be very useful because we could only have a small window in which we would catch the disease early and intervene effectively. The concept of lead time actually informs a phenomenon called lead time bias. Say that we're looking at the amount of time that people survive with the disease from the time at which they were diagnosed. If we are comparing people who were in a screening program to those who weren't in the screening program, we could get a biased comparison because of lead time. Lead time makes it look like those who were screened had longer survival with the disease, but it might actually just be that survival time has not increased, but rather that the diagnosis time is just earlier. So we can illustrate this better with a picture. So a person's trajectory might look like this if they are not on a screening program. The actual survival time from biological onset to death is 10 years. The measured survival time from diagnosis is 3 years. If they had been on a screening program, then their situation might look like this. Note first that the actual survival time is still 10 years. Screening was performed, but it didn't lead to a more effective treatment of disease, perhaps for many potential reasons. But one effect of the screening was that disease diagnosis was made 4 years earlier. In other words, the lead time is 4 years. Now the measured survival is 7 years, which appears higher than the measured survival of 3 years in the unscreened situation. Still, though, the actual survival time is 10 years. Ideally, with a screening program, death from this disease would be delayed or prevented, meaning that death would occur further along this time axis or be removed from this time axis. Removed meaning death due to this particular disease. Okay, so how do we deal with lead time bias? Well, for one, we could try to estimate the amount of lead time, which would involve understanding when people are typically diagnosed, when they aren't on a screening program. If we can estimate lead time, we want to see that the typical survival time in the screened individuals is greater than the typical survival time in the unscreened individuals, plus the estimated lead time. Another way to deal with lead time bias is to not look at survival times, but instead compare mortality rates in the screened and the unscreened. For this, we should take care to not pick too short a time span for the computation of mortality rates. Why is that? So say that in this example, we decided to compute a 5-year mortality rate from time of diagnosis. This would result in a high mortality rate in the unscreened, simply because diagnosis happens later. It's closer to time of death. But we're still in this situation where screening has not extended life. In both situations, the survival time from biological onset is 10 years. The 5-year mortality rate from time of diagnosis in the screened would be lower just because diagnosis happened earlier. We should choose the duration to be sufficiently long to make up for this lead time. The last bias that we'll discuss in the context of screening is length bias. Length bias can be expressed in a confounding framework, actually. Specifically, disease duration, so length of the disease, is a common cause of the result of a screening test and of health outcomes. So disease duration is a cause of the screening result because longer lasting, meaning slowly developing, diseases are more likely to be caught by screening. That is, they're more likely to test positive. Why is that? So as an extreme example, consider a disease that lasts a day before resulting in a death and a disease that lasts 10 years before resulting in death. A screening test is very likely going to miss the disease in the first case because the disease is over so quickly in 24 hours. So in fact, the longer the disease, the more likely it is to be detected, and the more likely it is to be detected early in its progression. Disease duration is also a cause of health outcomes because longer lasting diseases tend to be less severe. Suppose we want to evaluate the effect of screening on health outcomes among the diseased. So comparing those who screened positive to the unscreened people who developed disease would result in a flawed comparison. It would be flawed because those who screen positive tend to have longer and likely less severe disease. Those who are unscreened have a mix of long, less severe disease and short, more severe disease. So overall, this unscreened group will have worse outcomes than the group who screens positive. It would be better to use outcomes for all people who are screened, not just those who had a positive screen result, if we were to be evaluating the effect of the screening program. So in summary, we have outlined general conditions for evaluating whether screening is worthwhile, and more of these will be discussed in the next video. We've also discussed if effective and ineffective times to screen during the natural history of disease. We've discussed lead time bias, which can affect comparisons of survival times in those who are screened and not. We've also discussed length bias, which affects the evaluation of health outcomes.